كويس. طب ليه مش شغال اه تمام. بسم الله الرحمن الرحيم. Thank you, Dr. Wahid, Chairman. Uh, I would like to start this lecture by ده شغال؟ By the question, conventional radiography in cardiac diseases. Is there a role? First, my name is Ahmed Taefik. I'm Associate Professor of Diagnostic Radiology, Mansoura University. So the answer is yes, there is still a role. Until the time of this conference, there is still a role. We don't know the future or what the future will bring, of course, but the near future, there is still a role. The objectives of this presentation is to try to answer this question and take a brief look on the history of chest X-ray, a brief look on the anatomy, and present a systematic approach for the interpretation of X-rays. So X-ray was first discovered by Röntgen in December 1895, and in less than 6 months, we already had articles on chest X-ray, such as this shown. This images was published in Boston Medicine and Surgical Journal in 1896. So 120 years ago, or more than 120 years ago, this is how you used to transfer your patient to a hospital in Dallas 120 years ago. But since then, everything has changed. This is how you can transfer your patient to hospital, the flying ambulance. Well, almost everything has changed except chest X-ray. Chest X-ray has resisted time and change. It's still on top of all radiologic examinations. So according to the ACR appropriateness criteria, last updated in 2015-16, chest X-ray is still on top of all the list for almost all cardiac-related indications. As you can see here, the cardiac-related indications, and this is an example of the ACR appropriateness criteria. As you see, chest X-ray is on top of the list, and as you see, it always receives the rating of the highest rating for appropriateness in all cardiac-related indications. So why is that? Maybe because it's available, cost-effective, needs no preparation, has no contraindications. All of these are known for X-rays. But maybe also because it provides valuable information. So let's have a look on the anatomy on the chest X-ray, and as you can see, there are complicated or complex diagrams here. So let's go for a simpler one like that, showing the cardiac borders, the right border and the left border, the structures forming the cardiac borders. Or even more simple, this diagram showing the cardiac chambers, the arrangement of the cardiac chambers on a chest X-ray, as we can see. Now, let's go to the important part of this presentation, the approach to chest X-ray. You should have your own systematic approach for chest X-ray and for every radiologic examination, just not to miss something on your interpretation. So let's go through these 9 points here: the situs, the size, the chamber or the specific chamber, the shape of the heart, the aorta, the pulmonary, the lung vasculature, the thoracic cage and ribs, and the last one is the tubes, lines, devices, etc. So the situs, as we all know, there is situs solitus, where every right organ is on the right and the left organs are on the left. And then you have the situs inversus, which is a true mirror image of the situs solitus. So the right organs are on the left side and the left-sided organs are on the right side. Okay? And then you have the situs ambiguous, where it doesn't fit, the arrangement of the organs doesn't fit to a situs solitus or situs inversus, then it's situs ambiguous. Either you cannot determine the side of the organs, or you have bilateral right-sidedness, which is called right atrial isomerism, or left atrial isomerism, or bilateral left-sidedness. And with these, you have asplenia and polysplenia. So those are part of the spectrum of situs ambiguous, and not all the situs ambiguous should fit into those two categories. So on a chest X-ray, how to comment on situs? You should look for the heart position, of course, and then the position of the gas bubble in the stomach. Where is it, on the right or left side at this? The normal or the situs solitus. And you should try at least to look at the trachea and the bifurcation of the bronchi, just to get a hint on the bronchial anatomy if your radiograph was penetrated enough. So this is an example of situs inversus. And this is the CT of the same case. As you saw on X-ray, the heart is on this on the right side, and the gas bubble of the stomach is on the right side, so it's a situs inversus. Just to give an example, and maybe you can get the bronchial anatomy from here. The second point on interpretation of chest X-ray is the size of the heart. And as you know, this is a very, very, very old concept, the cardiothoracic ratio. This is a very basic measurement or ratio that you should try to do in all cases of chest X-ray. And of course, this is the right way or the right method to do your cardiothoracic ratio. You add A plus B over C. Okay? So what's new on the cardiothoracic ratio? There are many recent publications trying to correlate what you get on measuring the cardiothoracic ratio and what you really have, whether from cardiac MRI, from echo, from whatever the more accurate modality you have. So from this systematic review, we get very important notes on this point, that measuring cardiothoracic ratio on X-ray is highly sensitive, or more than moderately sensitive, but it's not specific. And the gain point or the main point is that it has a strong negative predictive value. Actually, really a good negative predictive value. So if you get on a chest X-ray a heart that is not enlarged, then you, in 83% of cases, the heart is really not enlarged. You can exclude cardiomegaly by X-ray in this case, okay? But if you get an increased cardiothoracic ratio, there are many reasons that we give you. Actually, most of them are technical reasons that will give you a false impression of an increased cardiothoracic ratio. So just take notice of these important points. Now we come to the shape, and there are many specific shapes with specific names that you could see with an X-ray. Actually, they are not very common, or are not that common, especially in this in this era where everything is diagnosed very early and nothing is left to be diagnosed at an end stage to get the specific shape. However, you should know something about those. One very important shape is, of course, the shape of the heart when there is pericardial effusion, the flask-shaped heart. This is how it looks. And of course, this is the CT. So in total anomalous pulmonary venous drainage, the type with a supracardiac drainage, there is this characteristic shape of a snowman. The heart looks like snowman. And this is, of course, there is this reference that you could have a look at such classic signs. This one is called the egg on a string, and it's usually seen or presumably seen with the TGA, transposition of great arteries. And of course, you know, everyone knows this boot-shaped heart in tetralogy of Fallot. Okay, there are, as I said, there are many other shapes. You could have a look on this on the reference I showed. So what about the chamber? Sometimes with chest X-ray, you could have a very good impression about which chamber is enlarged. So it's not enough to just say that there is cardiomegaly. Sometimes you have to try to see which chamber is really enlarged, especially when there is isolated chamber enlargement. So if you're trying to look at the left ventricular enlargement, what will you see? You would usually see this obtuse cardiophrenic angle, because the cardiac apex is shifted outwards and downwards, or laterally and downwards. And then this is the site of the cardiac apex, so the angle becomes obtuse. And you also see on the lateral projection that there is projection of this left ventricle on the lateral radiograph. What about RV enlargement? Of course, there is this, the angle becomes obtuse, the cardiophrenic angle becomes obtuse, and there is the most important one is the fullness of the retrosternal space. About right atrial enlargement, you could directly see the right atrium projecting on the right heart border. And of course, you usually see an enlarged right ventricle together with the right atrial enlargement. What about the left atrial enlargement? Of course, these are known classic signs for left atrial enlargement: the double density, the splaying of the carina, the left atrial appendage enlargement, and on the lateral view, there is the backward displacement of the left main bronchus and the posterior bulge of left atrium. All these signs are very well known. So this is the double density. This is the widened carina, and this is the normal subject. So you could have a look at how the widened carina looks like. And this is the left atrial appendage, of course, this last one. Now on the lateral film, sometimes more difficult to see, but there is the backward displacement of the left main bronchus compared to the normal subject on this radiograph, and there is the enlarged right PA is also seen, and this is the left atrial enlargement. It bulges on the middle to lower third of the posterior cardiac border here, compared to this place in the normal subject. Number 5, we come to the aorta. Now these are simple things to detect with the chest X-ray, but very, very important findings. And this one, of course, the right aortic arch is sometimes missed. If you don't actively look for the aortic knuckle on the left side, you will surely miss one or more of these right aortic arch cases, especially that they are usually asymptomatic. So this one was coming for just a checkup, and then you find that this is the right aortic arch. Of course, we all know that we have two types of right aortic arch, the one with mirror image branching and the one with an aberrant left subclavian artery. This is a diagram showing these two types of right aortic arch. And of course, these are the common types. There are other types, but much less common. So classically speaking, the right aortic arch with a mirror image branching is usually associated with cardiac anomalies, while on the other side, the aberrant left subclavian artery branching type is not associated with cardiac anomalies, or is more likely to present as an isolated anomaly of the aortic arch. So how can you differentiate? You can sometimes differentiate between the two types. You have to do a lateral chest X-ray, and of course, this is from the postero-anterior view. You see that there is a right aortic arch. Then you go and look on the lateral X-ray just to detect if there is indentation on the back of the trachea or not. If there is indentation on the back of the trachea, then this is suggestive of an aberrant left subclavian artery passing behind the trachea. So this would be this type, okay? This would be the type with an aberrant left subclavian. So now if you do a lateral X-ray and you find no indentation on the back of the trachea, as shown here by this red arrow, then you think, or you get a suggestion that this one is a mirror image branching type. Of course, this is not very, very specific sign, but usually it's a helpful sign. So aortic aneurysm, of course, you can sometimes detect this aortic aneurysm, a huge aneurysm of the ascending and descending aorta on chest X-ray, and it should prompt you to do a CT if the patient was not scanned before by CT. Of course, you have to look for the salute signs, and you have to be sure that this is not an enlarged mediastinum or part of the cardiomegaly. So you just look at the borders of or the cardiac borders, if they are showing or not, through the density or through the mediastinal opacity. And you should also look for the hilum, where is the hilum, and you should look for continuity of this large opacity with the shadow of the aortic knuckle or the shadow of the aorta. And what else do you have to look for? Okay. So now we go to coarctation. Sometimes you could also detect coarctation by chest X-ray, or at least suspect coarctation. Or in cases with known coarctation, you find these findings. The aortic knuckle becomes is small on a PA view, and you have the classic rib notching sign because of the intercostal collaterals, as we can see here. This is the CT angio of the case. Sometimes you have post-stenotic dilatation, as well as pre-stenotic and post-stenotic, and you get this figure of 3 appearance due to hypoplastic aorta or due to coarctation. So if you have aneurysmal dilatation here and there, you get the figure of 3 classic appearance also. Number 6. So we have covered until now 5 of the main points that you should comment on when you interpret a chest X-ray. And now we go to number 6, which is the pulmonary arteries. As a rule of thumb, the main pulmonary artery should be the same as the aortic knob. So if you find dilated main pulmonary artery only, then then you suspect pulmonary stenosis with post-stenotic dilatation.
دقيقة يا دكتور أحمد عشان نخلص ممكن.
Okay. If you have dilated main pulmonary artery and branches, then you have pulmonary hypertension. So this is the first type, only dilated main pulmonary artery, and here pulmonary artery and branches. So you have also pulmonary vasculature. You have 4 patterns for pulmonary vasculature. The first is plethora, when there are all the vessels are enlarged, and usually this is with ASD and VSD. ممكن 3 دقايق كمان. Okay.
لا يعني صعب لأن
تمام.
نسرع شوية دي.
هنسرع على طول.
معلش أنا آسف.
Okay, لا لا. Again, so the first one is plethora. The second one is oligemia, when you have all the vessels are small sized and there is decreased vascularity, and usually with pulmonary stenosis or tetralogy of Fallot. The third one is increased pulmonary venous pressure or pulmonary edema, and you have the classic signs of curly lines, the airspace nodules, the bilateral symmetric consolidations, and the pleural effusions. And the fourth one is pulmonary arterial hypertension, and of course this is the classic appearance when you have all the main and 2 branches and central branches are dilated, while there is paucity of vascularity here in the periphery. So there is this contradistinction between central are dilated and peripheral are even smaller than normal. Okay. Okay, just examples for pulmonary hypertension. So this one is number 8, the one before the last. And we have the thoracic cage, and please never forget to say that this patient has a sternotomy, a median sternotomy, and the sternal wires are seen. This is a very important finding. You cannot miss that on a chest X-ray and just not report the patient having a sternotomy. A sternotomy is a sign that this patient is most probably or 100% a cardiac patient. This patient had CABG, this patient had valve replacement, whatever the operation. So just never miss that this patient or your patient had sternotomy. The 9th and the last one and very important one is the lines, tubes, and devices. As we can see the pacemaker here, and you should report where are the leads of the pacemaker. Of course, you have many types, a single lead, a dual lead, a 3-lead pacemaker, and there are also the ICDs or the or these devices where you have a very thick electrode here. This is not a pacemaker, this is an ICD because this is a thick electrode. You also have the prosthetic cardiac valves, and you should try to see which valve was replaced from the X-ray, and here is the projection of the on the postero-anterior as well as on the lateral, and it's usually easier on the lateral to get where the place of the cardiac prosthesis or cardiac valve prosthesis, because pulmonary and aortic are above the line, and the mitral and tricuspid are below the line. And of course, you have the biologic and the mechanical cardiac valves. This is an example of aortic valve. The other one is a mitral valve prosthesis. And then there are devices that you less commonly will meet. but you should have some knowledge about these devices. For example, the mitral clip, which is shown here. I don't know if you see it or not, but it's very subtle. You should know that there is something called mitral valve clip, and then you can see it. This one here is very important one, an intra-aortic balloon pump, which works instead of the left ventricle and pumps the blood in the aorta.
احنا في الدقيقة الستة دلوقتي 6 minutes.
Just one slide. Okay. So the intra-aortic balloon pump here is shown by a radiopaque marker that should be lower than the aortic knuckle. Okay. Here an example of ASD closure device also. And this was my last slide, and thank you.